Good evening, everybody, and welcome to AnCan's webinar tonight with our guest speaker, Dr. Jonathan Epstein. As you can see on our welcome screen, this is information about the AnCan organization. We would like to let everybody know that the information and opinions expressed in this presentation, either verbal or written in the chat window or question and answers, are not intended or recommended by AnCan or its representatives for any medical treatment, product, or course of action. You should always consult your doctor about any specific situation before pursuing health programs or treatments. AnCan would like to thank their sponsors tonight. They include Bayer, Novartis, Myriad Genetics, Johnson & Johnson, Telix, Blue Earth Diagnostics, and Foundation Medicine. And without further ado, we will commence the webinar. Next up will be Rick Davis to introduce more about AnCan and our guest. Rick, you're muted.
Good evening, everybody. Welcome. I think this is going to be a terrific webinar. I think the last time we had Dr. Epstein on the show, if I remember correctly, it was New Year. It was like the end of the year, and I think we had about 300 odd people, and I don't know how many people watched it afterwards. So we're really excited. A couple of housekeeping things. The chat window is only for chat messages. It is not for questions. The Q&A function at the bottom of the screen is where all the questions should be placed. I will handle the questions that come in around high risk, recurrent, and advanced. Our board member, Stuart Jordan, and low intermediate moderator also will handle the low intermediate questions. Eric Milson, who is an active surveillance moderator, will handle the AS questions. Dr. John will ask the questions that have been previously submitted, and he'll rotate around us. So everybody's question will be handled. So we have in this webinar tonight 3 members of our advisory board. Our advisory board are by and large people who pick up the phone to AnCan, mostly to me, but in Dr. Epstein's case, he picks up the phone to all of our gents who send him in questions, and we're very grateful for that. We thank him immensely. The participants love it. So Dr. Epstein has been on our advisory board now for about 3 or 4 years. That's number one. Number two is the well-known Howard Walensky that has really been with us from very early days, and we're so grateful to have him on our advisory board. And then the third is Dr. John Antonucci, who is a very key volunteer and will be hosting the webinar tonight. A lot of where we interface with Dr. Epstein is through encouraging people at all stages of prostate cancer to get a second opinion on their biopsy slides. I would say our moderators are indoctrinated with that instruction, and we rarely get through any prostate cancer group at whatever level, and we have 5 different prostate cancer groups right now without somebody mentioning that they should send their slides to Dr. E for a second opinion. And if you don't know how to get onto one of our groups, then we'll put a link in the chat window for you, and you can read up about us and all our different groups, and not just our prostate cancer groups. So lastly, another quick thank you to the sponsors, and I'm going to turn it over to Howard Walensky to introduce Dr. Epstein. Thank you, and enjoy the webinar.
Okay, thanks, Nick. Well, it's like being heard, but I hope so. So, welcome to the webinar with Dr. Epstein at AnCan. This event is being presented just as Prostate Cancer Awareness Month is winding down. I hope you all had the best Prostate Cancer Awareness Month ever, although I'm sure you will agree with me that we should be saying that every day should be prostate cancer awareness. And today, with Dr. Epstein as a speaker, our awareness will be increased, and you'll be able to ask him some questions after his presentation, although you can submit those to the Q&A box now. I want to tell you a little bit about Dr. Epstein. He's among the world's leading genitourinary pathologists. He's widely recognized for his expertise in prostate cancer diagnosis, grading, and research leadership. I can tell you that he diagnosed my prostate cancer 15 years ago as a second opinion. After nearly a 40-year career at Johns Hopkins, Dr. Epstein opened his private practice in New York City earlier this year, advanced uropathology, and also medical professionals pathology. He provides second opinions on prostate cancer cases and other urological cancers. The numbers are huge with Dr. Epstein. He's made significant contributions to the field with more than 1,000 publications in peer-reviewed journals, 73 book chapters, 21 authored books. I don't know where he finds the time to look at slides. The numbers keep growing. He's delivered 417 lectures internationally in 43 different countries, and I guess he can tick one up to 418 now. He's trained 90 fellows in genitourinary pathology, many of whom have become leaders in the field. While at Hopkins, his group reviewed 12,000 cases per year. I'm curious to know how many he sees now that he's on his own. I have just a little bit more. Dr. Epstein refined and modernized the prostate cancer grading system. His work led to the development of a simplified 5-grade prostate cancer system aimed at replacing the confusing 25-score Gleason score system that's been in use for decades. I think without much more adu, I'm going to turn the platform over to Dr. Epstein. Please submit your questions in the Q&A, and I'm wishing you a happy rest of your Prostate Cancer Awareness Month.
Okay, can everyone see my slides?
Yes, I see them.
Okay,
I hope the audience does too.
Okay, so first I want to extend a very heartfelt appreciation for being invited to talk to you today from one of the premier groups in prostate cancer patient groups. And it's a great way to reach out to a lot of patients and hopefully address some of your questions and concerns. So first we'll talk about cancer, which is the biggest issue. And probably the most important issue in prostate cancer is the grading of cancer. So as was mentioned by Howard, Gleason grading system started in 1967. Obviously, from then until now, the field of prostate cancer has changed dramatically, as has the pathology. So the first major update to the old Gleason system was a 2005 consensus conference that I led. And then in 2014, there was another consensus conference which I led, which led to the new grading system that Howard mentioned, and I'll talk about with a little bit greater depth. So when we talk about grading, we talk about the patterns. Theoretically, there's patterns 1 through 5, but for the most part, we never talk about 1 and 2 anymore. They're all combined pretty much with pattern 3. And the pattern 3 is basically very simple, well-formed glands. So on the left is the original Gleason system. And so what Gleason was most notable for was recognizing that in contrast to other cancers in the body, when you looked under prostate cancer under the microscope, you often had 2, sometimes even 3 different patterns. So what he found was, whereas most other organ systems, you just say what the worst pattern is, and that's the grade. What he found was that if you had, for example, pattern 4, which is more aggressive, and pattern 3, the grade was somewhere in between 3 and 4, not just simply pattern 4. So what he came up was the Gleason system, which you say, what is the most common pattern? For example, if a tumor is 70% pattern 4, that would be 4 is the most common pattern. If it's 30% pattern 3, that's the secondary pattern. You would add that up together, it would be a 4 plus 3 equals 7, and 7 would be the Gleason score. Now on the right is our current schematic diagram. And you can see that pretty much, even though there is a patterns 1 and 2, as I'll mention, we never use those anymore. And that's where the new grading system comes into play, because it's confusing with the Gleason system having this patterns 1 and 2 that no one uses. For the most part, when you look at Gleason pattern 3 on the left, there are many patterns that today we would call pattern 4. So currently, the Gleason system pattern 3 is a very homogeneous, simple, uniform group with, as I'll show you, an excellent prognosis. Whereas in the old Gleason, a lot of patients with a Gleason pattern 3 or a 3 plus 3 equals 6 actually did poorly, and some of them died. It's important to recognize that with pattern 4, there are different histological patterns. Poorly formed glands, fused glands, but the one that's most important to recognize, and I'll talk about, is what's called a cribriform gland. Cribriform comes from the Latin word sieve. The way I tend to think of it more descriptively is think of it as Swiss cheese. It's a sheet with punched out holes in it, punched out holes. And that's what the cribriform glands look like under the microscope. So in the old system, again, we had Gleason pattern 4. In the new system, we have these 3 different patterns, the cribriform here with these little holes, fused glands, and then these little poorly formed glands. Gleason pattern 5 is the one pattern system that has not changed from the original Gleason to current. It's basically no gland formation. So these are very poorly differentiated tumors under the microscope, where one has either sheets of cells without holes in it, or just individual cells. So here again, pretty much similar between the old Gleason system and the new system. One thing about Gleason pattern 5 that we've done 2 studies on different patient groups to show is that frequently I find that pathologists do not call Gleason pattern 5 when it's present. Almost 50% of the time when I think there's Gleason pattern 5 present, the outside pathologist has not called it. And I think that starts from pathologists just not feeling comfortable giving the patient the worst possible grade, even though it may be present. It's important to be accurate at all grades, but with the higher grades, it's also critical to have an accurate grade when it's present and not undergrade it, because that's going to be important for treatment purposes. So some of the problems with prostate cancer grade that I see on a daily basis. So routinely, I review prostate cancer biopsies sent to me either by patients or clinicians, whether urologists or radiation oncologists, where they want me to look at a case that have already been diagnosed by an outside pathologist. And I commonly will change to a higher grade, meaning a 6 might go to a 7, or downgrade, meaning a 7 might go to a 6, which can affect a patient's candidacy for active surveillance. But grades are also important, not just with active surveillance, but for treatment in general, and I'll discuss that shortly. And I frequently change the grades, these higher grades, which again can affect treatment. Most of the time, it affects radiation therapy, because if one's going to have a radical prostatectomy, having surgery regardless of the grade, then it'll be the grade of the radical prostatectomy and the margins and lymph nodes and everything else that'll affect therapy. So the grade won't be as critical for men who are undergoing radical prostatectomy, but definitely affects radiation therapy and other forms of therapy. So of all the key aspects of pathology, grade is the critical. It's the foundation for any therapy that's going to be given for prostate cancer. Now, in addition to the grade, obviously the diagnosis is critical. And there are cases where somebody might be called cancer and I change it to not cancer. And obviously that's the greatest difference that one could have in terms of changing a diagnosis. So just to show one recent study, how grade changed, these are large cohorts of patients, and approximately 8% of patients who were diagnosed with a 3 + 4 = 7 or grade group 2 were downgraded to a grade group 1 or a 3 + 3 = 6 on radical prostatectomy. And as the authors mentioned, this is most likely as a result of overgrading the biopsy. So this 8% of men, if they were graded accurately on their biopsy, would not have undergone radical prostatectomy. They most likely would have undergone active surveillance. And so this demonstrates how overgrading of the biopsy potentially leads to overtreatment and emphasizes the paramount importance of accurate biopsy grading. So why is there discrepant grading? So first of all, let me say that most pathologists are good diagnostically and will grade accurately. However, there's a significant minority of pathologists, and about maybe 20–30% of the time I may change the grade, so it's not an insignificant number of times. And they may grade it, in my opinion, inaccurately, either due to inexperience or lack of skill, where there can be some blatant, I think, errors in grading. But the other thing is that grading can be subjective, and in those cases, it does rely on pathologists with extensive experience. So as Howard mentioned, and I briefly mentioned, in 2013, the group of myself and a group at Hopkins came up with a new grade group system to try to simplify prostate cancer grading from the confusing Gleason grading system to a simple 1 through 5 grading system. It's based on the modified or updated Gleason system, so it's not, independent of what Gleason came up with, but it simplifies it and is again based on the new current Gleason modifications. So grade group 1 is Gleason score 3 + 3 = 6 or below, so we don't care about patterns 1 and 2, 2 + 2 = 3, 4, 3 + 2 = 5. They're all combined as grade group 1. Grade group 2 is 3 + 4 = 7. Grade group 3 is 4 + 3 = 7. Grade group 4, probably 95% of them are 4 + 4 = 8. Uncommonly, one can have a 3 + 5 = 8 or a 5 + 3 = 8. And then grade group 5 is 4 + 5 = 9, 5 + 4 = 9, and 5 + 5 = 10. And just to show you from the risk of being cured at radical prostatectomy, where we have the whole tumor to look at, so we don't have the issue of sampling error, if one has a 3 + 3 = 6 or grade group 1, 96% of these men are cured. The reason why it's not 100% is some of them will have positive margins and may have local recurrence, but none of these patients will have distant metastases. Grade group 2, 3 + 4 = 7, still an excellent prognosis. 88% of men are cured. Grade group 3, 4 + 3 = 7 drops to 63% cure rate. 4 + 4 = 8, about half of the men are cured. And then a Gleason score 9 through 10, about a quarter of men are cured. So the new grade group system more accurately reflects the biology of disease than the Gleason system. So grade group 1, as opposed to a 6 out of 10, 6 out of 10 sounds like it's, worse than halfway there in terms of aggressiveness. But grade group 1 is the lowest you can get, so it's more intuitive, excellent prognosis. If one has a pure Gleason score of 6 or grade group 1 at radical prostatectomy, where we see the whole tumor, no patient will have a distant metastases. It's incapable of spreading out of the prostate distantly. Grade group 2, as opposed to a 7 out of 10, 7 out of 10 sounds like it's pretty high grade. But as I just showed you, grade group 2 has a very good prognosis and only rare metastases. Grade group 3, prognosis gets worse, but it forces, the problem with the Gleason also is 7 out of 10 is composed of 2 different groups, 3 + 4, which has an excellent prognosis, and a 4 + 3, which has a worse prognosis. So grade group 2 and grade group 3 forces that separation into 2 types of 7. Grade group 4, people used to combine them as through 8 through 10 as kind of poorly differentiated prostate cancer, but 8 has a significantly better prognosis, twice as good a prognosis as 9 through 10. And then grade group 5, we find that there's really no need to distinguish 4 plus 5, 9, 5 plus 4, 9, or 5 plus 5 equal 10. They're all the same as grade group 5. So currently we are using grade group in parallel to the Gleason system. So the way it's typically reported is adenocarcinoma of the prostate, Gleason score, for example, 4 plus 3 equals 7, parentheses grade group 3. Now it may come down the road that we do away with reporting the Gleason once everyone's comfortable using grade group and it's become intuitive for everyone. And we would just say grade group 3. But currently both are given, but they're synonymous. So we split Gleason score 7 into grade group 2, 3 plus 4 equals 7, and grade group 3, 4 plus 3 equals 7. And that's a major improvement, but can we do better than that? And so the recommendation that has come out of the major urological pathology societies is to report the percent Gleason pattern 4 when there is a Gleason score 7 on biopsy. And I'll show you how that's done. What I would say is, in my practice, looking at outside reports, maybe half or less than half of pathologists are doing this. And what we find out in general in medicine is that once something is reported and reproduced in multiple studies, recommended by societies, it still takes years for that to disseminate out and for the majority of people in clinical practice to adopt it. So let me explain the rationale for reporting percent pattern 4 when you have a grade group 2 on needle biopsy, 3 plus 4 equals 7. So with increased utilization of active surveillance for many patients with very low risk and low risk prostate cancer, which is Gleason score 6, some urologists are also considering active surveillance for select favorable intermediate risk. And I'll describe what that is. That tends to be low volume grade group 2 disease. Depends on multiple factors, life expectancy, patient desire, and other clinical and radiological factors. So the report of percent Gleason pattern 4 in cases with grade group 2 or 3 plus 4 equals 7 may determine active surveillance eligibility. So let me describe 2 cases, hypothetical cases, with a 3 plus 4 equals 7. So these are cores of a needle biopsy. So on the top, there's a core on the needle biopsy with 90% pattern 3, maybe 95% pattern 3, and then less than 10% pattern 4, maybe 5% or less than 10%. That patient could be a candidate for active surveillance, depending again on other factors. On the other hand, you could have a patient with a 3 plus 4 equals 7, as shown in the bottom schematic, where it's close to 50% pattern 4. That's a case that's bordering on a 4 plus 3 equals 7 or grade group 3. In my opinion, that would not be a candidate for active surveillance. But if a pathologist, and again, about half, if not more pathologists, are just reporting 3 plus 4 equals 7, you have no idea, or a clinician would have no idea, radiation oncologist, for example, or urologist would have no idea, is that a 3 plus 4 equals 7 that's closer to a 6, or 3 plus 4 equals 7 that's closer to a 4 plus 3 equals 7, if you don't give percent pattern 4. Now, there's also a rationale for reporting percent Gleason pattern 4 if you have grade group 3 or 4 plus 3 equals 7 on needle biopsy. And reporting the percent pattern 4 where the highest needle biopsy grade is grade group 3 could impact patients, especially with radiation therapy. So grade group 2, 3 plus 4 equals 7, is considered favorable intermediate risk with some of the caveats that I'll mention. Typically, those patients will not get hormone therapy, anti-androgen deprivation therapy prior to radiation. They just get radiation. When you have a grade group 3, 4 plus 3 equals 7, that's considered unfavorable intermediate risk. Many radiation oncologists, again, depending on other variables, will add hormone therapy prior to the radiation therapy. So again, pretend we have 2 different hypothetical patients with a 4 plus 3 equals 7. The top schematic is a patient with a 4 plus 3 equals 7 with 90% pattern 4, 10% pattern 3. That's a grade group 3 bordering on a grade group 4. That's bordering on a 4 + 4 = 8. If that's reported as 4 + 3 = 7 with 90% Gleason pattern 4, that patient would typically get hormone therapy prior to the radiation. On the other hand, in the bottom schematic, if there was a patient with a 4 + 3 = 7 with 60% pattern 4, again, this is kind of bordering on a 3 + 4 = 7. And so if that was reported as 4 + 3 = 7 with 60% pattern 4, typically that patient would get radiation therapy without any preceding hormone therapy. If, on the other hand, it's only reported as 4 + 3 = 7 without giving the percent Gleason pattern 4, who knows how this patient would be treated in terms of whether hormone therapy is given prior to radiation therapy. The oncologist, radiation oncologist, in a sense, is blind to what's going on, relatively blind to what's going on the biopsy. Now, once a pathologist gives a grade, which again is the diagnosis is obviously cancer versus not cancer is the most critical. After that, the grade is the most critical. And then we come to measuring cancer. And there are several different ways of measuring cancer. The simplest one is how many cores are positive. That can usually be done, but sometimes cores fragment and you can't do that. And you may also see in a pathology report if there's multiple cores taken from one site, typically on what's called a region of interest or a targeted site taken under MRI guidance. Some pathologists will say, given that there's multiple cores coming from one site, so it's all one area, what they do is think of that 3 cores, for example, as one long core, and they may give an overall percentage of the tissue involved by cancer. So they may not give the number of positive cores in that scenario. In addition to the number of positive cores, typically some other measurement is given, whether it's millimeters of cancer or percentage of cancer per core or both. And pretty much whether you give millimeters of cancer or percentage of cancer, their studies have shown either one is pretty similar to the other. Now, what I would emphasize to patients is that, for example, it's not infrequent that I get a case, again, signed out by another pathologist. And let's just say hypothetically, I agree in that case with the grade. I may have some disagreement with the extent of cancer. Maybe they call it 30%, I call it 20% of a core. What I would stress is the measurement of the cancer, the extent of the cancer is not that critical. What's critical for the measurement of the cancer is not whether it's 20% versus 30% or 10 versus 30%. What's critical is it 5% versus 90%, or somewhere along that lines? Is it a little cancer or a lot of cancer? Relatively speaking, in between, it's not that critical. The needle biopsy only samples 1/10,000th of the prostate. It's still an inaccurate snapshot of what's going on in the whole prostate. And again, it might be 10% on the needle biopsy, but it could be significantly different in the whole prostate. So again, the key thing is at the extremes, a little bit of cancer or a lot of cancer, but don't get hung up on 15 versus 20, etc. Now, another reason why you may see discrepancies in a pathology report is based on cancers that are discontinuous. So what I mean by discontinuous, and this happens not infrequently, so the red is a core of the prostate tissue, or basically a thread of tissue taken out from the prostate, and the blue is the cancer. And it's not uncommon to see a little speck of cancer on one part of the core, and then all that red is benign prostate tissue in between, and then another little speck of blue cancer somewhere else farther up the core. There's 2 different ways a pathologist potentially could report the extent of cancer. One is they could say, we're going to collapse those blue to say overall how much blue is in the total amount of the needle biopsy, how much blue relative to red. And they may say there's cancer involving 5% of the area of the core. The other way of reporting it is to say there are small foci of cancer discontinuously involving 80% of the length of the core. Looking at basically where does the cancer start, where does it end, and measure that as the extent of cancer. That's the way I do it. And the reason I do it is studies from our own institution as well as others, have shown that in the vast majority of cases, when you see a little bit of cancer, a lot of benign tissue, then another little bit of cancer separate, it's one big tumor just going in and out of the plane of section of the needle biopsy. So saying it as 80% involvement is a more accurate reflection of the size of the tumor than to say it's a 5% of the cancer. Another feature that we look for on the biopsy is perineural invasion. Perineural invasion is a predictor of extraprostatic extension at radical prostatectomy. It also helps to predict progression following radiation therapy. It is easy to assess. In contrast to grade, it's more reproducible for pathologists. It is recommended to include it on the needle biopsy. But what I would emphasize, in contrast to several other features that I'll be discussing shortly, it's not such a critical feature on a needle biopsy. Meaning, even though statistically there's an association with predicting extraprostatic extension and progression following radiation therapy, there's a lot of exceptions to the rule. And for the individual patient, whether you have perineural invasion or not, I would say is not going to determine your therapy for the most part, and is not so critical to predict prognosis. So I mentioned about other subgroups of patients with 3 + 4 = 7 who might be candidates for active surveillance. And so one, we talked about the extent of cancer. I talked about percent Gleason pattern 4. If you have 5 to 10% Gleason pattern 4, you might be a candidate. If you're 50% Gleason pattern 4, 3 + 4 = 7, in my opinion, you wouldn't be a good candidate. And then we'll talk about large cribriform versus no large cribriform glands. So the National Comprehensive Cancer Network, which is a major group that helps to recommend various treatment options for patients with all types of cancers, have come up with a term called favorable intermediate risk. So favorable intermediate risk is Gleason score 3 + 4 = 7, grade group 2, and less than 50% of the cores are positive. And then either you can have a very abnormal rectal exam or PSA of 10 to 20, but you can't have both a very abnormal rectal exam and a high PSA of 10 to 20 to be in this favorable intermediate risk group. That's their definition, but you'll notice in this definition, they don't have anything about percent Gleason pattern 4, which in my opinion should be involved. They don't have anything about large cribriform pattern 4. They don't have anything about intraductal cancer that we'll talk about. So from my standpoint, even though this is the definition by NCCN, I think it's not including all the key factors that should be into really deciding who's a candidate for active surveillance. Now, when you look at outcomes for active surveillance, this is a huge database from SEER. The good part about SEER is it's huge numbers. The bad part is it's not like you have an expert in neurological pathology grading these cases. They're graded by any pathologist who's been in any of these institutions. So to some extent, it's not as accurate, but it does have the benefit of large numbers. But what you can see here is if you look at the low-risk patients, those are Gleason 6. And if you look at the blue curve, those are patients who have low risk who are treated with active treatment, whether it's radiation therapy typically or radical prostatectomy. And then in the red, you see the low risk with active surveillance. And you can see these two curves are superimposed on each other. And what that means is, if you are low risk, you should be doing active surveillance for the most part. Again, there may be some caveats, but for the most part, you should be doing active surveillance because you're going to have the same outcome as if you undergo a treatment with much greater morbidity. But if we look at even the favorable intermediate risk group, so on the bottom diagram, we look at patients who have a favorable intermediate risk group, the blue line, who undergo active treatment. And again, the line is higher, which means they have a higher overall survival than the red line, which is favorable intermediate risk, who are under active surveillance. So if you just go by the NCCN favorable intermediate risk group that I just mentioned, and all those patients undergo active surveillance, overall, those patients are not going to do well as having treatment. But again, as I mentioned, that favorable intermediate risk definition, from my standpoint, doesn't take into many other factors that should be looked at when deciding if somebody with a 3 + 4 = 7 undergoes active surveillance. So in terms of percent pattern 4 and how important that is for active surveillance selection criteria for 3 + 4 = 7, and is there a cutoff for percent pattern 4 that's helpful to identify which men with a 3 + 4 can undergo active surveillance? And even though there's no official cutoff, what I would say is many urologists use kind of the less than or equal to 10% Gleason pattern 4 with a 3 + 4 for considering active surveillance. And again, I would say it's somewhat fluid. And it also depends in large part on the patient age. If you have an older patient, you could probably end up, increasing that to 20% and still be recommending active surveillance. What is not out there and what is necessary is eventually to have long-term follow-up with patients of men on active surveillance with 10%, 5%, 20%, 30%, Gleason pattern 4 with information on large cribriform or not, so we can actually see how those men do. And right now, we just don't have that data. Now, as I mentioned, one of the patterns for Gleason pattern 4 is cribriform glands. And the vast majority of studies on prostate cancer with this cribriform architecture, in general, has found this to have worse clinical outcomes and molecular features typically seen in more advanced cancer. But the important thing is when you have these cribriform glands, these glands that look like Swiss cheese, it's been shown that how big those cribriform glands can affect the prognosis, meaning small cribriform glands may not have a worse prognosis, but many studies have shown that these large cribriform glands are associated with a worse prognosis. So what I do and what's been recommended by the large urological pathology societies is that when there's large cribriform glands present or absent should be reported for both 3 + 4 = 7 and 4 + 3 = 7, grade groups 2 and 3. I would say, again, where maybe 50%, maybe 40% of our pathologists are reporting percent Gleason pattern 4, probably 5 to 10% of pathologists are reporting whether there's large cribriform glands present. So that's something, it's just not out there yet that's happening with any consistency, unfortunately. Again, I think we need good long-term follow-up studies of men on active surveillance with cribriform glands. But from my standpoint, at least at this current point, if a patient that I diagnose has large cribriform Gleason pattern 4, 3 + 4 = 7, I would recommend them not undergoing active surveillance. Now, in addition to having a cancer diagnosis or a benign diagnosis, sometimes you'll see that the worst diagnosis in a case is atypical, suspicious for cancer. So what are these atypical biopsies? Some of them are cancers, but they're so minimal and difficult to diagnose that they're just not diagnosable with 100% certainty. And we don't diagnose cancer unless we're 100% certain. Some of them are benign mimickers of cancer that pathologists without as much experience do not recognize that these are benign mimickers, and we'll call them atypical. What's been shown is that the majority of cases that are called atypical by a non-expert, once reviewed by an expert, most of the time can be more definitively diagnosed as either totally benign or as cancer. So in general, I would say if you have as your worst diagnosis atypical, suspicious for cancer, and you're considering, do I need a repeat biopsy? How closely should I be followed? You should get that biopsy reviewed because it could be totally benign and you're home free, or it could be definitively cancer, and that's a whole different paradigm of where to go from there. The risk of subsequent cancer, if you're diagnosed with atypical, is on average 40%. Now, the other thing I should mention is it's not uncommon to have cancer on one or two or multiple parts of your biopsy, and on another part of your biopsy may be atypical. In that scenario, you can ignore the atypical. It means nothing if you have cancer elsewhere in the biopsy. That's what's going to dictate your treatment and prognosis. So what should happen if somebody has, as the worst diagnosis, atypical suspicious for cancer? So there is follow-up warranted. Either follow-up with serum, urine test, maybe imaging. They could be repeat biopsy with relatively increased sampling of the atypical site, If the initial biopsy was not done with MRI guidance, it should be repeated with MRI guidance. It's variable what urologists will do with an atypical sign out if that's the worst. Some urologists will not rebiopsy after an atypical sign out because most cancers found after an atypical diagnosis are grade group 1, and those patients might not be treated even then. But there is about 15-20% following an atypical diagnosis that are higher grade and you would want to diagnose. From my standpoint, if a patient were to ask me, what should I do if my worst diagnosis is atypical? I would recommend getting a repeat biopsy. Number one, you could have worse cancer, but even if it is a grade group 1, then you're followed more closely, which I think is the correct way to go. You'll also see potentially as another diagnosis, prostatic intraepithelial neoplasia, PIN. Low-grade PIN, you should never see a low-grade PIN being diagnosed. Should never be in a pathology report. It has no prognostic significance, no reproducibility, and patients can be worried about it, which could lead to unnecessary procedures and concern. Now, if you have a single core as your worst case, worst part in the biopsy with high-grade PIN, and there's no other cancer in the biopsy, no atypical, again, the only thing you have in your biopsy is a single core with high-grade PIN. For the most part, you can ignore that. There's no increased risk of cancer. If there's multiple cores with high-grade PIN, there is an increased risk, about the same risk as having an atypical finding on biopsy, and the same discussion goes into play that we just had as to whether to undergo repeat biopsy or imaging. Again, it's somewhat a matter of a discussion with your urologist. A much more worrisome finding is intraductal cancer. So intraductal cancer, first of all, looks different under the microscope than high-grade PIN for, again, pathologists that know what they're looking at. The reason why intraductal cancer is a much more aggressive finding and worrisome finding is that it's typically associated with high-grade cancer and poor pathology at radical prostatectomy, meaning tumor out of the prostate, seminal vesicle invasion, lymph node metastases, etc. And it has a worse prognosis once it's treated with, for example, radiation therapy or hormone therapy. Most of the time when we find intraductal cancer, it represents invasive high-grade cancer that's broken into glands and spreading into those glands. So it's a sign that there is higher grade, worse cancer elsewhere. However, that's not always the case. Sometimes when there's intraductal cancer, it can be the only thing in the prostate without any invasive cancer. And in that case, it's a precursor lesion to high-grade cancer. So if you have intraductal cancer as the only bad thing on your biopsy, meaning there's no invasive cancer, again, there's kind of two different options. One is to still undergo definitive therapy, whether it's radiation or radical prostatectomy, even if you don't see invasive cancer on the biopsy, because this is a bad precursor lesion. You don't want it just sitting there in your prostate. The other option, and many urologists still say, I want to document invasive cancer and see the grade before I operate or radiate somebody with intraductal cancer. So the other option is to do repeat biopsy in these patients with intraductal cancer. So again, intraductal cancer is typically associated with invasive cancer, but not always. It has a worse prognosis, and it does mean more resistance to radiation or hormone therapy. It doesn't mean that if you have intraductal cancer, you shouldn't undergo radiation or hormone therapy, but it's a relative resistance to these forms of therapy. So it's very important to recognize intraductal cancer even when there's invasive high-grade cancer elsewhere in the biopsy. So one of the questions that comes up is, if I have high-grade cancer, what's the importance of getting a biopsy? What's the importance of the pathology if I already have advanced cancer? And the finding of intraductal cancer is one of these features that you want the pathologist to look for if you have advanced cancer, because that may determine, for example, surgery versus radiation therapy. In a younger man, if you have intraductal or a lot of intraductal cancer, that might be something better treated with surgery, for example, as opposed to radiation or hormone therapy. Another term you may see in your pathology report is atypical intraductal proliferation, or AIP. AIP has some but not all features of intraductal. So we came up with the definition of intraductal cancer many years ago, and we came up with a very stringent criteria under the microscope for diagnosing intraductal cancer because it is such a bad feature and some patients may be treated solely based on that diagnosis. So we wanted to make sure we had very strict criteria. Consequently, there are sometimes under the microscope, there will be some findings that we look at that have some features of intraductal cancer, but not fully making the definition. But within the definition of atypical intraductal proliferation, or AIP, there's a spectrum. Some are more suspicious for intraductal cancer, and some are not as suspicious. So it's critical, if you have AIP suspicious for intraductal cancer, even if that patient would be otherwise a good candidate for active surveillance, I would typically recommend repeat biopsy to rule out intraductal cancer before undergoing active surveillance. But if it's AIP that's kind of not that worrisome, then probably that patient could undergo active surveillance. So if, again, you ever get a diagnosis of AIP on your report, you want to talk to the pathologist or, again, send it to an expert and talk to that expert to see how bad is this AIP. Is it close to intraductal cancer or potentially not that worrisome? Now, talking about more aggressive prostate cancers, there's a couple subtypes that I'll mention. One is called prostatic duct adenocarcinoma. So usually when we diagnose prostate cancer, and that's over 95% of prostate cancers, if we were to formally call them, we would call them acinar adenocarcinoma of the prostate. But because these are kind of the usual typical prostate cancers, we don't even put the word acinar in there. We just call it adenocarcinoma of the prostate. But when you just say adenocarcinoma of the prostate, it's presumed that we're talking about the usual or acinar type. There is this other type, 5% or so of prostate cancers, that's called prostatic ductal adenocarcinoma. It looks different under the microscope. 1% of the time, it can be purely prostatic ductal adenocarcinoma, and another 5 to 10% of the time, it can be mixed with usual prostate cancer. Now, the term ductal terminology is confusing. So I just mentioned intraductal cancer, and now I talked about ductal adenocarcinoma. And you might think, oh, they're the same, but in fact, they're actually very different. Intraductal cancer, which I was talking about just before, which I said is a bad prognostic feature, that it relatively not as well responds to radiation or hormone therapy. Intraductal cancer means it's growing within pre-existing ducts within the prostate. It refers to location. Ductal adenocarcinoma refers to what it looks like under the microscope, and so they're different. So prostatic ductal adenocarcinomas typically, not always, can arise around the urethra where the urine goes out. They can actually project into the urethra as a papillary lesion. They can mimic bladder cancer. And one of the pitfalls is pathologists can misdiagnose them as bladder cancer. And patients don't always present like typical prostate cancer. They present just like bladder cancer with obstructive symptoms, hematuria. The rectal exam is often normal, and they're diagnosed on a transurethral resection. The way we grade prostatic ductal adenocarcinoma, most of these are Gleason pattern 4. So if you had a pure prostatic ductal adenocarcinoma, it would be graded as a Gleason score of 4 + 4 = 8. A minority of them can have Gleason pattern 5, Gleason scores 9 through 10. And there's a newer variant, which actually has a good prognosis. It's relatively rare. And again, most pathologists have trouble recognizing it. But it's also important to recognize that stage for stage and grade for grade, prostatic duct adenocarcinoma has the same prognosis, meaning a 4 + 4 = 8 prostatic duct adenocarcinoma has the same prognosis as a 4 + 4 = 8 usual prostate cancer with the same stage. Now, in contrast, one of the most aggressive prostate cancers is small cell carcinoma. So there are some clinical features that can suggest small cell carcinoma and that are different than usual prostate cancer. So usual prostate cancer, when it typically spreads to a distant site, they go to lymph nodes and also to the bone. In contrast, small cell carcinoma often goes to solid organs, meaning liver, the brain, adrenal, not to the bone. Also, usual prostate cancer is typically what we call osteoblastic, meaning once the prostate cancer spreads to the bone, it stimulates the normal bone to rapidly proliferate so that the bone becomes very dense when you have this prostate cancer in them. In contrast, small cell cancer, when it spreads to the bone, tends to destroy the bone. Prostate small cell cancer tends to have huge lymph nodes, which would be uncommon for usual prostate cancer. And also small cell cancer does not make PSA. So a very low PSA in the setting of high volume bone metastases is a clue that you may be dealing with small cell carcinoma. Also, small cell carcinoma does not respond to hormone therapy. So if somebody has advanced prostate cancer, they get treated with hormone therapy and the tumor doesn't respond at all or responds only for a short period of time, that could also be a clue for small cell cancer. Now, again, I use the word suggestive. None of these are diagnostic of small cell cancer. The only way to make a definitive diagnosis of small cell carcinoma is by the biopsy. And again, for patients with advanced prostate cancer, asking the question, why do I need a biopsy if I have advanced prostate cancer clinically? The answer is you want to rule out small cell cancer because small cell carcinoma is treated very differently. It's a high grade, what we call neuroendocrine cancer. It can be pure small cell cancer or can coexist with usual prostate cancer. Most patients present right off the bat with small cell cancer, but there's a subset of patients who have a prior history of usual prostate cancer, and many of them are treated with hormone therapy. They develop castrate-resistant to prostate cancer, and the castrate-resistant kind of can select for these high-grade neuroendocrine cancers to develop. So we are seeing an increase percentage of patients with small cell carcinoma of the prostate as we see more and more patients being treated longer and longer with some of these newer anti-androgen therapy. And the good news is more and more patients are living longer on anti-androgen therapy. The bad news is a small subset of them are developing small cell carcinoma. And again, the critical part of small cell cancer is the treatment. So you treat them with chemotherapy, the same that's used in small cell carcinoma, which is most commonly found in the lung. You don't do radical prostatectomy, typically not radiation therapy or hormone therapy. The prognosis of small cell cancer, overall, it's a very prognosis. Overall, all patients have only a 10-month survival. If it's clinically organ confined, they have a 20-month survival, but very few patients relatively have a 20-hour organ confined. That's why the overall survival is so dismal. It's a major problem for pathologists to diagnose small cell cancer. Either they can overdiagnose it or underdiagnose it. And it's very not uncommon for a Gleason score of 5 + 5 = 10, which is usual prostate cancer, to be misdiagnosed as small cell carcinoma. And the reason is regular prostate cancers, 5 + 5 = 10, not small cell cancers, can have neuroendocrine differentiation on special stains, meaning if a pathologist is unaware and they think, oh, could this be small cell cancer, they can do certain tests on the tissue that could be misleading for them to end up leading to a misdiagnosis of small cell carcinoma. Now, let me talk a little bit about artificial intelligence, or AI, in prostate cancer. Slides, in order to have AI done on your prostate biopsy, slides have to be scanned. These are expensive equipment to scan, hundreds of thousands of dollars. Most labs do not have them. They can be sent out to be scanned to certain private companies. But again, it's not a simple matter necessarily. The scanned slides are then analyzed by various computer programs. The computer programs for diagnosing graded prostate cancers are based on analyzing many biopsies of benign and cancer, but it's based on who's diagnosed and graded the cancer. So if whatever that program is that's out there, commercial program, use somebody who's not necessarily a great expert in prostate cancer, then the AI is being trained incorrectly. And so that's going to determine the accuracy of the program. So what is my thought on potentially the role of AI in prostate cancer biopsies? One, the way AI is set up, it can help avoided pathologists to underdiagnose small cancers. How is that done? So what happens with AI, what AI can be set for is to say, find anything abnormal on this biopsy that's not just typical benign. Because the whole purpose of AI is it doesn't want cancers to slip through and be underdiagnosed. Now, so AI is set for maximum sensitivity to identify anything abnormal. But if it's set for maximum sensitivity, therefore it's not going to have good specificity as to everything that it's called isn't going to be cancer. But what it can do is if the AI says, I don't see anything abnormal in this biopsy, that can reassure a pathologist that a case is totally benign. It can also help with some standardization of grading. Studies have shown that AI is equivalent to a general pathologist grading. It hasn't been shown to be more accurate grading than prostate cancer experts. A problem with AI is there's a lot of benign mimickers of prostate cancer. There's also unusual variants of prostate cancer, like I mentioned, prostatic ductal adenocarcinoma, small cell carcinoma. There's a lot of others that I'm not going to mention today that are very unusual. The AI hasn't been trained on them, so consequently the AI won't even recognize them. Also, what you realize when you look at slides from different laboratories, even in the same laboratory day by day, there can be variations between the labs in staining, artifacts, knife marks, and all of these things can cause problems with the AI, whereas an expert can basically deal with them. So again, I think AI does have maximum sensitivity, but there'll be less specificity, meaning AI by definition is going to overcall cancers in order not to miss any cancer. And that's up to the pathologist then to look at the slides and to say what's going on and is the AI being accurate or not. Now, also, every AI software has a disclaimer saying this is not a diagnostic test. It's an adjunct and we are not medically liable. It's not a substitute for the pathologist. So consequently, the pathologist is ultimately responsible for accepting or rejecting the diagnosis proposed by the AI. The way I think of it is it's like driving with a car currently that has some of these semi-autonomous driving programs. You're still supposed to be not in the backseat playing, watching TV. You're supposed to be there with your hands on the wheel in case there's something wrong with the AI of the car. And it's the same thing with pathologists using AI, looking at the AI diagnosis. To me, a potential pitfall is that some pathologists will start relying too much on AI, which could lead to diagnostic errors. They'll start thinking the AI is infallible, which it definitely is not. So in summary, there's a wealth of information you can obtain from the biopsy pathology report. Ultimately, it depends on the accuracy of the pathologist. Critically important to have high-quality pathologists to get your best diagnostic and prognostic information for your patients. With that, I'll thank you.
Thank you, Dr. Epstein. We're going to go over to John Antonucci, who will be hosting the next portion of our webinar. John?
We're going to take a few minutes for Dr. Epstein and Dr. Jones to discuss AI. Not very long, though, because we need plenty of time for questions. But would you guys like to have a little discussion about AI? In the case of Dr. Epstein, this would be about pathology. In the case of Dr. Jones, it'll be about MRI imaging.
Yeah, thank you. That was a great presentation, Dr. Epstein. I learned a great deal. Pathology is on the other end of the spectrum from where our business participates. We're on the front end with early detection and quantifying of the disease and qualifying of the disease. I wanted to say to the audience and to you that I agree with every one of your comments about some of the pitfalls of AI. We have the same problem in the radiographic training of our AI model and any AI model for that matter, because it is tremendously dependent upon what we call the biological ground truth. And that means it's only as good as the data that has been fed to it. And if there were a lot of mistakes made by radiologists in the beginning, then that's a problem. Now, one of the things that we've done to address that in radiology is that we trained our particular product on the pathology slides, and therefore we've limited it somewhat. But again, one of the challenges that we have and that we share with pathology and with urology is that we're only sampling a small total volume of the entire gland. So as a pathologist, you see 15 millimeters of one sample, and you have to form your grading from those 15 millimeters. So my question to you is, do you feel comfortable with that knowledge that there may be 5 needles or 12 needles plus 2 targeted? Do you have a comfortable feeling of the amount of tissue sampled in that particular patient?
Yeah, it's a good question. So I think definitely a major game changer has been the MRI, multiparametric MRI sampling. In general, and I'll qualify that, it tends to find the worst cancers. It's not infallible, meaning I see cases on a daily basis where the target has either no cancer or low grade cancer and the randoms have the higher grade cancer. But overall, maybe 80–90% of the time, the targeted will have the higher grade cancer. So it is better than what it used to be, but it's still not infallible. Meaning, even with the greatest technique that we have now, best radiological technique, you still have the risk of missing worse cancer because sometimes worse cancers can be small. And that's why patients undergo repeat biopsy. One biopsy is not sufficient. And so everybody I talk to who's going on active surveillance, I always recommend, even if they had their first biopsy with MRI, I would say you need a repeat biopsy in a year from then to see what's going on. Not that the cancer gets worse over time, that doesn't happen, but you're still looking to see, did we potentially miss worse cancer initially?
Right. Yeah. And that's a common complaint, if you will, for lack of a better term, that we hear from our urology clients is just that fact that radiology has not done an excellent job of identifying the true cancers. Again, because we have the same problem in radiology as you do on a pathology slide. There's a lot of mimickers out there. One of the things that differentiates our AI from every other one out there in the radiographic space is that we use a technique called random forest that is trained at the voxel level. That's a millimeter cube, basically, in a standard MR image. And we can differentiate from 1 millimeter to another, whether this is highly suspicious of a high-grade cancer or not. And so we actually have an internal grading system that this has been pseudo-calibrated to those pathology grades that we can point out not only in the one dimension of what we call the Z-axis, the cranial caudal or head to toe, such as a biopsy needle represents, but we also then, the program has been trained well enough that it can show in the axial planes the extent of those same voxels with the same behavior. So what we're saying is that the morphology that you see on a slide, we have trained the algorithm to recognize the effect of the MRI images to then show the extent of the cancer in all 3 dimensions. And we're really making a major game-changing contribution here now to where physicians can see the entire extent of the suspicious cancer throughout the entire organ after a 15 or 20-minute MRI. Sadly, the uptake of new technologies is slow, as you know, in the medical community. So that's just another reason why I like to participate in these type of conversations and stuff, to let people know that there are other choices out there. We share your opinion. You should get a second opinion, but it should start with the diagnosis and detection and end with the pathology.
Let me cut in there and let Dr. Epstein respond to that, and then I'm going to start getting to questions.
No,
Sure.
I really don't have a response. I think I agree with everything, so we can just jump into the questions.
Very
Thank
good. Actually, one of my questions that was written, and it was on the MRI and pathology stage. Here's the question. On follow-up MRI tests for active surveillance people, is it okay to do the MRI without contrast?
Absolutely. If your software has been trained on those 3 sequences that are non-contrast sequences, such as ours. So we show a 94% sensitivity specificity of detecting clinically significant cancer with no contrast.
And here's one for Dr. Epstein. It was one of my write-ins, also from the active surveillance community. Could you make sure that he covers his thoughts on whether a biopsy can actually spread the cancer?
No, so yeah, that's a good question. A lot of patients have that concern. And the answer is there's really no evidence that cancer spreads, biopsy will spread cancers. Partly because now we're using very small needles. So in the olden days, decades ago, with the larger needles, it did spread sometimes. But currently, you don't have to worry about that and worry about getting repeat biopsies. There are other problems potentially with repeat biopsies, with scarring, etc., but not spreading of cancer.
How wide is that core, by the way, nowadays?
Typically like a 20 gauge. I mean, it's very, very thin. And that's why you
Okay.
can just stick a lot but a lot of needles into the prostate.
Here's a write-in for of having to do with intraductal cancer. Somebody asked if intraductal cancer would influence the recommendation for surveillance. Now, that basically comes down to a question of, is anybody with intraductal cancer appropriate for surveillance, active surveillance?
I would say you can't say nothing's 100%. Meaning if there was a 90-year-old man, for example, with intraductal cancer, for whatever reason he got biopsied, I would say, he could still undergo active surveillance because likely he's going to die before anything would happen with the intraductal cancer. But for the standard patient population that we're thinking, men in their 60s, 50s, 70s, for me, intraductal cancer, if it's verified, because again, it's not a straightforward diagnosis, if it's verified by an expert, intraductal cancer to me would exclude. I would not recommend somebody undergoing active surveillance. Again, depending on their morbidity and everything else, but for the routine patient, I would not recommend it.
Let me take a couple of questions from Eric Milson from the active surveillance community. Eric?
Hello.
Hello.
Just somebody asked, what's the definition of a cure rate?
It's a good question. And there are multiple different definitions. So I'll start from kind of one to the extreme. So one cure rate is what's called biochemical cure rate, meaning let's just say you have surgery or radiation. It means that your PSA stays extremely low. That means there's 0 recurrence. That's a biochemical cure, total cure. Now, some patients can have a recurrence of their PSA, meaning the PSA goes up after surgery or radiation, so they're not totally cured. But on the other hand, they could still live for 10, 20 years and die of something else. So you could look in that setting and say, yeah, they're not totally cured, but from a really practical standpoint, they were cured. And then there's patients who have metastatic disease. You would not say they're cured, but still potentially, depending on some things, could die of something else also, less likely. And if somebody dies of prostate cancer, obviously by definition, they're not cured. So there's different kind of gradations of what I would say is cured. And I think it's also important not just to think of cure, because, for example, one of the arguments of active surveillance, even with more aggressive cancers, is to say, patients aren't going to die of it in 10 years. On the other hand, many of those patients, let's say with more aggressive cancers on active surveillance, may develop distant metastases. They may not die in 10 years, but they may have bone metastases, which has horrible morbidity and pain, and undergoing hormone therapy, which has a lot of morbidity. And so it's not a good quality of life. So I think it's important not only to look at death rates when we're talking about cure, but look at, for example, metastatic rates, because once somebody has metastases, it enters into a whole different quality of life issue.
Let me interject there, Eric. Eric, I'm going to ask you to ask another question, but first make a couple points for you people that are writing questions in. Please don't ask any personal questions. If you have personal questions, bring them up and we'll discuss them in group, or just write to Dr. Epstein about consultations. Also, there is supposedly a way on your screen, which I don't see, where you can, if you see a question that you are also interested in, you can uptick it a little bit so we know which questions are very popular ones and can give them priority. Eric, got another one?
Yes, this new My Prostate Score 2.0 test, which I think is a urine test, is before the biopsy, and it justifies whether you need a biopsy. Does that play a big role in terms of needing a biopsy or not?
That's not something that is kind of in my domain, so I would defer to a clinician on that.
Sure.
That would be a good question for a urologist. Stuart, how about a couple questions from you for the intermediate risk community?
Dr. Epstein, I wanted to follow up on the urine test, but I want to ask it in a slightly different way. If you have any experience in terms of consistency of what these tests are saying versus what you see when you see slides.
Yeah, so many of the tests don't correlate obviously perfectly with what we see under the microscope in the grade. What I would say in terms of all these tests is that at least currently everyone's looking for the holy grail where you don't need a biopsy. You can be treated for prostate cancer based on some test or imaging, and I would say we are not there yet. Before anyone would give treatment for prostate cancer, because all these tests have false positives, you need to get a biopsy to document what's going on.
There was also, there's always a lot of interest in terms of the use of equipment. And someone had asked a question in terms of, do you see when you're looking at samples, whether one type of needle versus another is actually giving you a better sample to read?
It's again a very good question. There's definitely a tremendous variability on a day-to-day basis and between different urologists, even could be within one urologist from patient to patient on the quality of the biopsies. Sometimes certain patients are hard to biopsy, whether it's their body type, whether it's difficulty just in terms of their anatomy or the pain. And you see just very poor quality biopsies, very short cores, mostly muscle, not prostatic tissue. So in that scenario, even if it's totally benign, in a sense, it's kind of a suboptimal sampling. And if the pathology is reported accurately and describes how that's not an optimal biopsy, those patients may need a repeat biopsy sooner than later. And there are also various kind of newer biopsy guns or biopsy mechanisms out there that have shown, at least preliminarily, that they get better cores, less fragmented cores, thicker cores. And so those are, being, again, kind of going into the workplace, and some places are adopting it and others are not. It becomes a matter of kind of commercial adoption. But there definitely is tremendous variation in quality of biopsy. That's an important factor.
Here's a write-in question about neuroendocrine small cell cancer. In cases with intraductal carcinoma and cribriform, you mentioned already that they have a poor long-term outcome. How many of those actually do transform into small cell?
Yeah, so intraductal carcinoma typically doesn't necessarily transform into small cell. What typically transforms into small cell is a 5+4, 5+5, higher
Have that
grade
question.
prostate cancers over time.
Rick Davis, want to come on screen and ask a couple of questions?
Actually, Eric stole my cure question, so I can't answer that one again. I was gonna have a little chat with Dr. E about cure, because I get very nervous about that word cure. So I'd like to hear Dr. Epstein's view on what men with advanced cancer, recurrent and advanced cancer, who are nervous that their cancer is morphing into small cell. How can Dr. Epstein be helpful to those men?
Yeah, so what I would say is that two things. One is if you ever see your report saying small cell carcinoma or even the word neuroendocrine anywhere in your pathology report, that's when you need a second opinion. Because there's a high likelihood that somebody could be overdiagnosed or underdiagnosing small cell carcinoma. And it's a very difficult diagnosis. And one of the reasons why it's extremely difficult, and I'm saying it can be challenging for me as well, is that it's not straightforward. It's probably the most difficult diagnoses in prostate cancer because there are some cases that are classic usual prostate cancer and classic small cell. Those are the easy ones. But as I talked about, and as you just mentioned, you can have a usual high-grade prostate cancer kind of morphing or changing. We use the word transdifferentiating to small cell cancer. And sometimes the biopsy catches it halfway in between. So it's kind of halfway between a usual prostate cancer and a small cell cancer. And the question is, what do you do with those cases? They're extremely challenging. And there are some cases where you have to just say it's halfway in between. And I give my recommendations how to treat and follow those patients. But those are the cases in particular that a true real expert will not be able to diagnose accurately. The other thing that I didn't mention in my talk that's important is that if you've been treated with radiation therapy or hormone therapy and then are getting a repeat biopsy to look for recurrence, those biopsies and the pathology can be particularly challenging. And the reason is hormone therapy and radiation change can make the cancer look worse, can make it look aggressive, when in fact those are the cancers in that setting have responded well to the treatment. They're kind of in a quiescent sleeping stage and are doing well and don't need more therapy. But if a pathologist is not familiar what treated cancer looks like, they may overcall them as aggressive cancers. So I would say anybody who has a history of treatment, radiation or hormone therapy, and then is diagnosed with cancer, that's again a particular group that you want to have expertise on to say whether the cancer shows no treatment effect and you give it a grade and that's what goes on, or the cancer shows treatment effect and you don't give it a grade, and those are good actors.
Should they be redirected to liquid biopsies or just make sure to be redirected to a specialist?
Typically, you want the pathology reviewed to see is that, again, truly recurrent high-grade cancer, which does need some additional therapy, or is it a cancer with treatment effect, which means that patient's doing well. The cancer treatment has done what it's supposed to do.
Thank you. Rick, you get another question because your first
Well,
one
can
got
I
stolen.
can I just follow up on that one? Which is that, so a lot of times with these men with advanced cancers, and they haven't had a biopsy read since back in the day when they were diagnosed, and now they've got lesions left, right, and center, unfortunately, and maybe in the liver and soft tissue, maybe in the lymph node and in bone. Where would you prefer to see a sample to best identify a morphine cancer?
Sure. Yeah, so
Great
typically it's done with interventional radiology. They're the ones who typically do these biopsies. And typically what they will do will go after the easiest, most accessible deposit of tumor. One that's hopefully closer to the skin, or typically they will go after non-bone. The problem with bone, as I mentioned, biopsying bone can be very problematic. It can be very dense bone and you might not get a good sample. You can biopsy the bone, and we see it all the time. But if you can get a biopsy sampling of a soft tissue specimen, that's probably preferable.
And I will follow up on what you just said about the impact of hormone therapy and radiation. So a guy who's had radiation and has had extensive hormone therapy may never know what his true Gleason is, because the only time he ever got a Gleason score was when he had a biopsy. So is there anything that we can do to give that fella an indicator, any type of cell morphology you can look at as to how aggressive his cancer is?
Yeah, so most of the time, men with advanced prostate cancers, most of these decisions are going to be based on the clinical. How much the disease is expanding, what's going on with the PSA. If it's staying low, that's it's assumed that's good. But again, there are certain signs that clinically can point to potentially small cell carcinoma that I mentioned in the talk, that would lead them to potentially get a biopsy. Now, what I would, some clinicians may think, and some have said, we can diagnose kind of small cell cancer based on the clinical, and my experience, that's not true. You need the tissue. So if anyone's going to be treated for small cell cancer, which is again a totally different treatment than usual prostate cancer, you want to have it documented histologically.
Thank
Great
you. Back to
questions.
you, Dr. John.
And back to you, Eric.
Yes, a lot of people are new to this biopsy thing. So is there anything sort of like a minimum standard they should be requesting from the urologist as far as MRI targeting or any of those buzzwords that people talk about?
Sure. Yeah, so in my opinion, if I were somebody who was getting a prostate
Going to get
biopsy,
what?
in my opinion, if I was getting a prostate
Wait,
biopsy or recommending
did
to
you
a
say
family
cinnamon?
member,
Bill, you got to mute. Bill. Bill?
I'm sorry, I did not mean to unmute.
what I would recommend is undergoing an MRI guided, multiparametric MRI guided biopsy. Or at least having a multiparametric MRI and the biopsy. If the multiparametric MRI doesn't see a lesion, then you get your 12 cores or 14 cores kind of randomly distributed throughout the prostate biopsy. If they see a lesion, and sometimes you might see 1, 2, even 3 lesions, they call it region of interest or targeted, you still want those random biopsies in addition to the target. You don't want only a targeted biopsy, because sometimes the random biopsies will have the worst cancer. But you then want your random biopsies, 12 cores, plus sampling of a targeted lesion. How many cores they sample each target, to some extent, is based on how big the area is, how big the target is. Typically, they'll do 3 cores, usually, of a targeted lesion on MRI. Now, some urologists will not do an MRI and they'll just do a routine biopsy up front. It's more expensive. Not everyone has the MRI, harder to schedule, but it is the optimal way of going about it.
I would like to also add that, again, utilizing AI for that adjunct to the radiology interpretation is extraordinarily helpful. That second opinion shows where all the potential targets can be, because the sensitivity is higher than that of a radiologist. So there's your targeting right there in 3 dimensions for the urologist to do a much more effective biopsy.
Thank you.
Excellent.
Eric,
Thank you.
another question from you, please.
For me?
Yeah, you got one?
Yeah, I guess the big question a lot of people are asking is, who can order the second opinion? Is it the doctor or the patient? And how do I go about doing that?
Yeah, that's a good question. So it's happened several different ways. One way, for example, if somebody wants a second opinion, the easiest thing is to email me. I think my email is that they put on the chat the link, and it'll have my email. And I'd like basically get back to the patient with how to go about submitting a form. But ultimately, the easiest way is to ask your clinician to ask the lab where the biopsy was done to send the slides off for a second opinion. The lab will be more responsive to your clinician asking for getting the second opinion kind of in the works than if you do it. But ultimately, it is your slides, it's your material, you have ownership over that, and you can contact the lab directly and say, please have my slides sent to Dr. X. There are a few labs that put, I wouldn't say roadblocks, but they make it a little bit more challenging. There are some labs who will say that, for example, Dr. Epstein has to request himself the slides be sent to them. And if that's the case, you just let us know, and then we fax a request to those hospitals. I would say certain institutions and laboratories are better at getting the consults sent expediently. Others, you have to keep bugging them. There's just no other way to say it. But ultimately, no lab should ever resist you sending the slides off for a second opinion. And you should never feel hesitant to ask for a second opinion. You're not, insulting anyone. It's the bedrock of what's going to be your treatment going forward, and you want to make sure you have the right diagnosis.
Absolutely.
Thank
Stuart
you.
Jordan, come in with a question, please.
Sorry, phantom, phantom lesions where MRI shows nothing and something shows up in a biopsy. From your experience, does that create any additional challenges in terms of what you're looking at?
Yeah, so it's not under the microscope, whether it's a lesion on MRI or not seen on the MRI. We still look at it the same way. We still assess it and grade it the same way. So it's not an issue for the pathologist. It's more the reason why I mentioned why you don't want to have only biopsy of the targeted lesion, why you want those random biopsies. Because sometimes certain lesions, for whatever reason, are MRI silent or phantom, as you call it. And that's where hopefully the random biopsies pick it up. And as I mentioned at the onset, nothing is foolproof. So you can have a totally benign biopsy and there still potentially could be a cancer lurking there, even sometimes a higher grade lesion. And that's why if you're undergoing active surveillance, you get a repeat biopsy, what's called a confirmatory biopsy, typically a year or so after the initial one.
Another one, Stuart. Please.
Well, I'll just follow up on the confirmatory biopsy. Is your experience that those are just as critical to get a second opinion? We're telling every guy when we meet them up front and they're first being diagnosed, get a second opinion. Is the same true when you're dealing with confirmatory after the fact?
Yeah, I would say so, because that confirmatory biopsy is, again, going to, in most cases, end up determining therapy.
Rick, next question, please.
Yes, so I'm going to take a question that is being voted up on the Q&A from Robin Runyon, and it says, when Dr. Epstein provides a second opinion, does this also include what treatments are generally the most successful given what he's seeing?
Right. So what I would say is the following. The report just describes the pathology. It doesn't typically describe treatment because it's much more complicated and based on multiple factors. What I do tell patients is I am accessible, willing, look forward to discussing if a patient wants their pathology with me. It doesn't cost anything. I don't put a time limit on how long I talk to them over the phone. I will sometimes, depending on their pathology, provide treatment guidance based on their pathology. I'll ask them also questions about their health, their morbidity, their age, desires, etc. But ultimately, I can't know everything about that patient as compared to the treating physician. So even though I will provide my opinions on some therapies, which sometimes I think some are better than others based on the pathology, ultimately that still empowers the patient. They have more knowledge, but they should take that knowledge back to their clinician and discuss that, because their clinician, again, knows more about the patient than I do. Now, sometimes I talk to patients and they say, I just, my clinic, again, most clinicians are good. I'm not criticizing clinicians as a whole, but there are some patients who will say, my clinician just, doesn't have the time to talk to me. I feel like I can't, address certain things. That's up to you to find the clinician that you're most comfortable with.
Remember, there's a great deal of information, prognostic and predictive and clinical imaging information that the pathologist does not have.
Yeah, for example, yeah, exactly. So for example, somebody could have a Gleason score 6, 3+3, but there could be a PIRADS 5 lesion or a very high PSA. What that tells me is that patient needs a repeat biopsy to make sure that there's not a worse cancer there.
Rick, we're closing in on the end, but there's time for you to ask another question.
For me,
You get two.
I just got one. I'm busy answering questions on the Q&A side as quickly as I can.
All right.
Okay, let me
I'll
take
switch.
a very quick. I was just saying, let me take a really quick look and see if anything's been voted up high.
Okay.
Yes. And actually, this is a question. This is a great question because I've answered this about 3 times already, Dr. E. Daniel Pertrup writes in, great talk about histopathology. I think, if I'm not mistaken, Daniel Pertrup is a doc because we met him at PCRI. Great talk about histopathology, but what's the relevance in genetic or molecular testing on the biopsy specimen? And I've had a number of questions that have asked me, well, do I need to get a decipher and a biopsy reading? So maybe you could talk about how these molecular sampling tests interface with the biopsy reading, and can we have one without the other?
Yeah, I think it's an excellent question. So first of all, you need the biopsy. You're not going to do the molecular. First of all, the molecular testing is based on the biopsy. So no matter what, you need the biopsy. And again, the molecular testings don't replace the biopsy, but I think the molecular test can be an adjunct and give some information to the biopsies. So for example, in our laboratory, pretty much all cancers undergo, if the patient wants, it's up to the patient, decipher testing. But there are other tests out there, Polaris, et cetera. The way I look at these molecular tests is it provides an additional piece of information. Just like the MRI provides some information, the biopsy provides information, the PSA provides information, so do these molecular tests. So if, for example, you have a low-risk prostate cancer and you get a decipher or any other molecular test, and it comes back as a higher risk or more worrisome test, that's the same as having a PIRADS 5 maybe, or a high PSA with a good biopsy. It's a red flag that maybe the biopsy is not sampling the worst tumor. And before, let's say, you undergo active surveillance, you would need additional follow-up closely and more sampling. On the other hand, let's say you're thinking of undergoing active surveillance, you have a good, favorable pathology, you get one of these molecular tests that comes back as low risk. It's one more piece of information that gives you some comfort level that truly you have a low-risk tumor and you feel more confident undergoing active surveillance. It doesn't mean you shouldn't have, let's say, a confirmatory biopsy down the road, but it gives you that one more bit of confidence that you're on the right path. So I think these molecular tests do provide additional pieces of information that when they're in sync with the pathology makes you feel everything's all going, makes sense. And when they're at odds with each other, that's a red flag that maybe something is worse there. You're not going to be treated solely based on, let's say, the molecular test if you have low-risk pathology, but it's a red flag to get an additional biopsy sooner than later. And if you haven't had an MRI guided, make sure it is MRI guided on the second biopsy to make sure that there isn't worse cancer there.
I don't want to exploit Dr. Epstein's generosity too much, but I will go a little bit over time. Eric, can we have one last question from AS?
Yeah, I saw one earlier that was interesting, and that's somatic testing. Is a second opinion on the slides more important, or somatic testing more important? And is the somatic testing degrade the slides?
So somatic testing is different. So somatic testing is genetic testing to look for various molecular abnormalities in your cancer. Most of these somatic abnormalities, the number one, they're found in a very small percentage of cancers, and they're typically found in the higher grade cancers. So when you're talking about molecular testing for prostate cancer, not the Decipher test, but we're looking for BRCA1 and 2, for example, or ATM, some of these other markers, mismatch repair genes, you're typically looking at the more advanced cancers. They're the ones that are higher risk to having these abnormalities. And so for patients with high risk prostate cancers, it could be high grade, Gleason 8 through 10. It could be the presence of intraductal cancer, large cribriform pattern cancer. Those are the patients that you may want to undergo genetic testing that's different than, for example, the Decipher or the Polaris test. There you're actually looking for certain genes that can predict prognosis and sometimes help with therapy as well. But it doesn't replace the pathology.
Got it. And it doesn't degrade the slides, is the other part of that question.
Right. It doesn't grade the slides. It's looking at something totally different.
Got it. Thank you.
Stuart, last question.
There was a couple of quick mentions asking about after focal any sort of focal ablation. Does the same comment apply as with you talking about radiation or hormone in terms of making it more difficult to get a good biopsy?
Is this a question for the MRI person or for?
No, for you.
Yeah, so post cryotherapy, in a sense, is an easier biopsy for pathologists to look at. So as I mentioned, post radiation or post hormone therapy can affect what the histology looks like under the microscope, and can, for pathologists who are not aware, they can lead to overcalling an aggressive cancer when in fact it means the cancer's responded well to therapy. With cryotherapy, it's pretty straightforward. The cryotherapy either kills the cancer or it's there. It doesn't change what the cancer looks like under the microscope. So the purpose of the cryotherapy for the pathologist is to document where the cancer is still present, if it is, so that potentially additional cryotherapy can be targeted to those areas.
Yeah, and you can get a repeat MRI after a cryo or a radio frequency therapy. So it's a good option if you're doing focal cancer treatment.
Thank you. I want to thank everybody for your wonderful and well thought out questions. I know there's a lot left. Bring them to group, right to Dr. Epstein, right to Dr. Jones, and we'll try to get everything answered. I want to also thank Dr. Jones for your contribution, and a really big thank you to Dr. Epstein for coming back and talking to us. I'm going to turn it over to Bill to close out the session. Bill, go ahead.
All right. I believe Rick wanted to say some closing things, but I will say for those of you that your questions didn't get answered, as John said, if bring them to group or contact Dr. Epstein or Dr. Jones. If it's something that doesn't apply to any of them and you want to send it to info@ancan.org, we'll try to field it or get you pointed in the right direction. I won't give you any advice. I'm basically a glorified security guard, so you don't want any medical advice from me.
Let me just also clarify in terms of advice. Again, I'm more than happy to give advice, but before I give advice, I have to look at the slides, because I'm not going to give advice based on somebody else's pathology report, because if that's inaccurate, ultimately I could be giving you the wrong advice, and I don't want to be doing that.
Thank you. Rick, closing remarks?
Yeah, just a couple. There were a lot of questions. We tried to answer as many of them as we could, both live and offline. But there are many questions that were really treatment oriented, and what sort of treatment should I get if I have this? What sort of treatment? That, whilst I'm sure Dr. Epstein is well aware, we don't want to put him in a position where he's making treatment recommendations, especially when he hasn't seen your slides. So we would encourage you, please, to come to group. You can go to ancan.org. You can sign up for one of our 5 prostate cancer groups. And by the way, we've just added for the first time ever a gay and bi men's prostate cancer group. So we encourage you, if you fit that bill, to come to that group. It will be moderated by peers. So please come along. I will echo my thanks to, well, first to Howard, because Howard maintains a wonderful ongoing communication channel with Dr. Epstein. So if we need to get to Dr. Epstein in a hurry, we know how to do it. And so huge thanks to Howard and the active surveiller. Huge thanks to our advisory board member, Dr. John Antonucci, for doing a wonderful job in hosting and filtering the questions and keeping everybody in line. Thank you. Thank you very much, Dr. By the way, for those of you who are wondering, Dr. John is a pain psychiatrist and neurologist. That's it. That's his background. And he is a peer, and he does moderate our advanced prostate cancer group, as well as our Men Speaking Freely group, for which we are very, very grateful. We love Dr. John. And then, of course, the biggest thanks is to Dr. Epstein for this webinar, for being on our advisory board, and most important, for being willing to talk to all you guys who sent your slides in, because we know how important that is to you. And Dr. Epstein is proof that pathologists don't all live in caves. So with that, I want to thank you. Don't forget, if you enjoyed this webinar, you can always make a donation. We really rely on that, as well as our sponsors. And we hope that everybody listening will show up in one of our many groups. And with that, I'm going to say thank you and good night.
Thank you for
All right.
putting.
Thank you.
Good night,
Thank you.
everybody.
Sleep well.